is. Okay, let's move into what I think might be the most fun part, which is what would you do if it was your eye? And real concise answers here, guys. Let's start with this. You're 45 years old. Your pressure's 25. You live close to an ophthalmologist or close to an SLT, let's say. Uh, what treatment do you want to start with, Justin?
Maybe nothing. Do I have any OCT loss or visual field changes? Anything at all? Because
No, normal OCT, normal visual field, pressure 25.
you say OCT is normal. Sorry.
Both are normal.
Yeah, I'd sit on it. I'd watch it.
Lori?
I have extremely thin corneas, and I probably have a really low hysteresis, so I would probably elect to treat with SLT.
Mike?
Yeah, same as Lori. I would treat with SLT. I've got family history of glaucoma.
Okay, now we've got a little bit of red on that OCT or just a little bit of thinning. Justin, do you change anything?
At 45, yeah, I'm gonna do SLT.
Lori and Mike, same thing as what you did before? Yep.
Yep.
Okay,
Yes.
so you do the SLT and you get 1 millimeter of mercury decrease from it. What do you do next, Mike?
How long has it been?
That was a year afterwards.
I'd repeat it.
Repeat the SLT. Yeah, okay, Lori?
That's a great thought. I would consider that as well, but probably be looking at a drop that won't change my iris color.
Ooh. And okay, tell me more.
Um, this makes me sound really vain, but I have like hazel eyes, and so if anyone's going to change to brown with the prostaglandin, it'd be me. And I don't want to lose my hazel eyes. So I have patients that say this all the time. So, and I don't want to do Timolol either because I have a super low blood pressure. Like if I stood up right now, I'd probably pass out. But so I'd probably do, I don't know, I might try bromonidine or something like that.
Yeah, okay, wow. And that just goes to show how much better doctors women are than men most of the time. Because I would guess that most of us with that defective Y chromosome wouldn't, think about this nearly as much as we probably should have. Justin.
Yeah, I'd consider repeat, but it sounds like it wasn't very effective if you only got, a millimeter, I think is what you said, of mercury drop. So I'm probably going to a drop. And to your point, John, I would do a PGA. And that sounds like a bad decision right now.
Wow, Justin.
Lose.
Yeah, for sure. Okay, great. So now fast forward, instead of being 45, you're 68. Same story. You've got a little bit of change on your visual field. You're not on any medications. You do have an early cataract. You're not on any meds. Justin, what are you doing?
I want to know how concise, I want to know how much the cataract's bothering the patient. If there's visual complaint for me, I add a drop
Yeah,
and
I don't mind. I don't mind my vision. It's just that sometimes those headlights at night bug me.
yeah,
So I
then
don't
I'm
drive.
moving forward. I'm moving forward with cataract plus MIGS. I'll start a drop and then cataract plus MIGS. Stents in my case, to be specific, I would recommend stents plus cataract surgery.
Okay, Lori.
I would do the same thing, but I'd probably want a pair viscodilation with a stent because I just feel like I would need a low target.
I don't like it. Mike.
I would do cataract plus goniotomy and an iDose. Because I'm not on drops, you said. So I'm conscious of insurance and worried about not getting coverage. So I'm going goniotomy plus
Got it.
iDose.
And so I'm going to push at you for a second, Mike, because I agree with Justin. I do stents and cataract surgery, and I'm probably not doing an iDose yet.
I want
But
I want really low pressure like Lori, and I want to ensure that I don't need to add a drop back on. Keep going.
okay, sounds good. And so why not, I think that one of the things that I like, presumably this is optometrists watching this podcast, what I want is as much freedom to use the treatment that I think is best. So do you think that the better treatment is a goniotomy in that scenario, or do you think the better treatment is a stent? And I would say that I think the better treatment is a stent, and so I would want them to be put on a drop so that I do have all of my options, so that the artificiality of the insurance reimbursement world doesn't dictate what the right treatment is.
Why do you before I answer, I'm going to ask you a question. Why do you feel stent greater than goniotomy?
The safety profile and the high quality data that exists.
Yeah. And so I don't disagree with you. I think both
Do
would
you
be great.
agree with me?
Uh, yeah, I agree with you. Well, I don't want to agree with you.
Well, I don't know
No,
what
I'm
you
just kidding.
want. I feel
The
like
beautiful
you do.
the beautiful thing is, I mean, they're so close in their safety profile and they're so close in their effectiveness, that you can't go wrong. And I just
Can I
wanted
add
to give a
another
different
thing?
answer. I wanted to give a different answer than Justin.
Can I can I give another angle to this? Because we're, again,
Nice pun.
as optometrists watching this podcast and you're talking to your patients, I think the other thing is by jumping to a goniotomy, I always think about this for you, John, is I don't want to remove other options for you down the road. And if we strip that drainage system, I've removed the option of probably you putting stents in. I mean, you'd have to find a different part of the angle. But by doing stents first, now I know down the road that you could come back and do a goniotomy in between the stents, or you can remove the stents and do it around there. And so I always think about it as how many treatment options can I preserve for the future for that patient? Less about efficacy and which one's better or not better. They're probably equally as good, but what's the right order to do it to preserve more options for my patient in the long term?
I just want a bigger straw in there. I want to get that defective TM out.
Yeah, sounds good. Now, Lori, you said you figured you needed in particular a low pressure. Is there any reason why? I presume it's around your low blood pressure.
Yeah, I just feel like I'm set up for NTG. So I'm actually just hoping you're going to cure NTG by the time I'm 68. But
Got you.
yeah, super low blood pressure, thin corneas, migraines, Raynaud's. I got it all. I'm like the textbook. So I feel like I'm going to need a low pressure. So to quote Paul Singh, who says he's always going to hedge his bets, I think if we're in there doing a stent, I'd want to go ahead and flush out that outflow system with some viscodilation. I think it's a nice thing to pair with stents, and you don't really eliminate any downstream options, like Justin was saying.
I'm going to push on you a little bit, but I'll come back and step back from my pushing back in a second. Are you doing that more theoretically and philosophically, or are you doing that more evidence-based?
I mean, I'll admit it's more
Yeah.
philosophical. Yeah, we don't have any data to support that really. I mean, we know viscodilation can work for several years, and we know stents can work for several years. We know that most of the resistance is at the trabecular meshwork, but not all of it. And so full system flushing makes sense.
And, I feel like sometimes people use evidence-based as a weapon to make other people feel bad. And that's not the reality of it. And so how I think about it, and when we train our fellows, we talk about the decision that you make really boils down to what would you do if it was your eye? And that's why we're asking the question this way. And our job is to take the evidence, our experience, our ability to think what makes sense, and put that all into what's right for that one patient. So there isn't evidence that covers every situation. And you've got low blood pressure. Well, they didn't sort out people that had low blood pressure and Raynaud's in these studies. And so we have to make these judgments based on all this stuff. Let's go to angle closure. You're 40 years old. You've got a narrow angle. It's got some PAS. You are plano. What do you want? Justin?
That's a tough one. I mean, the Eagle trial, as Lori referred to earlier, would be remove it and move forward, but I don't think at that age I would want that, so I would prefer an LPI.
Okay. Lori?
I think that, can I still accommodate? Am I in readers?
You're 40. So
40,
yeah, you can
so-
still accommodate it. But it's
Okay.
going a while.
Yeah. So I think most of the time, as long as you're under the care of an ophthalmologist or an optometrist that's monitoring your OCT and your angle, angle closure can be kind of caught and intervened on at the right time. So if I just have some PAS, I think LPI is reasonable to wait and see what the angle does over time. But yeah, I would hate to lose that accommodation just for some PAS. Like those are technically, okay, they're not harmless because they're impacting outflow. But if they aren't too broad and extensive, I think I would probably just hold off.
Okay, Mike.
But yeah, I'm taking that lens out. I'm putting in a multifocal IOL. I'm having you do some goniosynovial lysis and probably popping in a couple stents because we're in there and I'm living the good life. I can sleep at night. I don't have to worry about pressure spikes, PAS. I've fixed two problems very safely. That's
Heal
right.
with steel, baby.
That's right.
All right. Okay, so now Justin, you're a +4. Same
Yeah, I'm going Mike's
scenario.
route.
Yeah, Lori,
Oh,
+4.
+4. I'm going Mike's route.
Yeah, for sure. Agree with that. I mean, it's a great chance to get yourself some free refractive surgery right there.
-4.
Same.
I'm
Yeah.
sticking with my first answer on that one.
Okay, Plano, age 55.
Take the lens out for me.
Yeah, same here. I mean, that's Eagle trial. I believe everybody was 50 or older. So, yeah, hands down.
Okay, so I think that what we've all agreed on is that well, not all agreed. Mike didn't agree, and I didn't say, but uh, if you're Plano and have accommodation still, it's not a no-brainer. If you aren't Plano or you've lost accommodation, take out the lens. So I think that that's where we're at. Now, let's go back to that 55-year-old Plano, whatever, -1. What lens are you having, Justin?
Any visual field loss or anything? Is this glaucoma or is this just narrowing?
This is mild glaucoma. Keep in mind, mild glaucoma has damage to the optic nerve, but no visual field loss.
So no visual field loss. Any implant is open for me. So, for me personally, because I've had previous refractive surgery and I would do light adjustable lens for me. But any implant's open in that case, in my mind.
Okay, Lori?
I think I go back and forth daily on this. I just had a conversation with John Gertz in Omaha yesterday about what lens we would pick for ourselves. Assuming that we're kind of curing my disease by taking out my lens and that my glaucoma is not going to progress, I'd be tempted to do panoptics, but I have also had refractive surgery. So LAL would be on the table as well for me.
Mike?
Yeah, I mean, echoing what those guys said, but to be different, I would do trifocal. Good news, there's studies out there that show patients with mild glaucoma, as John mentioned, no visual field loss, they do really, really well with these trifocals. They maybe have a touch more glare, maybe don't get as much near, but they still get really good range. And a little teaser, we're doing a study across some of the Vance Thompson sites asking patients, patient-reported outcomes, how much do you like your selection of your lens, whether it was a toric, LAL, multifocal, whatever, in these patients that also had glaucoma surgery at the same time. And so we'll know more on that once we get that data, and we'll certainly share it. But in general, yeah, these people have lots of options. It's great.
I would also have a trifocal for sure. Currently that'd be the Panoptics for what's available currently is what I would have in my eye. And I think that one of the keys is like that philosopher Yogi Berra said, predicting the future is easy, being right is hard. And I think that the key piece, if you're going to even start to push the limits on some of these technologies, is having a surgeon that can do an IOL exchange, safely and with impunity. And so I think of it like you're giving a patient a shot at the vision they want to have for the rest of their life. And if you don't even give them that shot, that's probably a miss. And so we as surgeons have to be able to do an IOL exchange and be willing to do it, especially if we're going to push the limits on the technology a little bit. Okay, you got bad glaucoma. You've had cataract surgery. You've had MIGS. Maybe you've had another MIGS. You're on full drops. Things are getting worse. You're 75. Your pressure is 17 and getting worse. Lori, what surgery are you having?
Zen.
Justin?
Zen.
Mike?
Uh, yeah, man. I I'm kind of
And
thinking maybe micropulse. Uh,
micropulse.
yeah, non-invasive. See what we can get. Uh, and if it doesn't work or I don't get to where I need to, then I still got Zen tube in my back pocket.
Okay, great. I'm doing a Zen. What, if it was me, what if that pressure was 13? Does that change your mind, Lori?
Yeah, if I'm progressing at 13 and we're really confident of that, I would probably sign myself up for a trabeculectomy.
Justin?
I'd probably still try Zen, educate the patient. I'm going to watch you really closely, and on the horizon is probably a more aggressive surgery.
Tuber trap. Mike? Micropulse? Do you
Yeah.
call it micropulse just because it says Mike in it?
Yes. Yes. I'm probably doing the same thing, and I'm also starting to look real hard on what future treatments are coming and what other lifestyle things I can do because pressure at 13 is hard to get a lot lower to make it worthwhile, and so I'm checking out what else is available.
Yeah. And when you look across the MIGS literature, MIGS devices don't consistently get you below 15 or 16 typically. And that makes sense because there's episcleral venous pressure as a back pressure. And so really, they don't work as well in normal tension glaucoma or glaucoma that needs to be kind of in below 15 or 16. I don't mind trying it because some patients do get better than that, but I don't. I'm doing that to give them a shot at a safer surgery. Any other what would I do if it was my eye questions that you guys have that you think would be helpful to the optometry listening community?
I, we didn't
What
touch
about
much on
pseudophase?
pseudoexfoliation,
Okay.
um, and not that you treat have different treatments available for it, but man, pseudoexfoliation can get really bad really fast, and so that's where being aware of it, identifying it, treating appropriately, and treating early really makes a difference. And I think with all the glaucomas, just early treatment is key, early intervention, so these people don't lose any function.
So let's just talk about that for a brief second. Pseudoexfoliation, in the upper Midwest where we practiced, where it's pretty homogenous, and there's not a lot of African American glaucoma, it's a little easier to treat glaucoma because African American glaucoma is harder to treat. That said, pseudoexfoliation can be very difficult to treat, and we have a lot of that up in our neck of the woods, especially because of the Northern European populations. A couple of thoughts. One, Mike, I couldn't agree more that the real goal that we have in glaucoma is make sure people are sighted when they pass away and that they've lived a visually full life. That's our goal. And so towards that, MIGS may buy us 10 years, may buy us 2 years, may buy us 20 years. But the longer we can push off doing more aggressive surgeries, the better. And in particular, in pseudoexfoliation, because those zonules are weak a lot of times. And when you change those flow dynamics, you can see that lens moving all around the place, coming forward, being in a different position. And so even though pseudox is aggressive, I really don't like doing aggressive glaucoma surgeries in them, even though we have to, because their lens isn't stable.
Agree. I think you mentioned the lens moving around, the vitreous can move around too, which is even more of a pain in the butt, in my opinion, is if you do a beautiful trab and there's vitreous in the AC the next day. So yeah, I think earlier intervention is awesome in those folks, but we know that pseudox gets even harder as you get older. And those really elderly folks, 80s, 90s, that walk into your clinic with high pressures, it's really hard to stomach signing them up for a big incisional surgery. So Mike mentioned micropulse. I think, thank God we have non-invasive cyclophotocoagulation for that age group, and I've used it several times in that situation.
Yeah, and one of the things that's interesting for cyclophotocoagulation, and I don't know, do you do ECP, Lori?
I do not. I mean, I will occasionally for plateau, but I don't routinely use it for pressure lowering.
So it's not particularly satisfying to me when I do the surgery. It's cool to look at, but it's not really satisfying. So we did a study combining ECP with stents, and it worked better. And I was kind of, if I was being real honest, subconsciously hoping it wouldn't work better, so I didn't have to use it anymore. But it did work better, and I like that for my patients, so we use it a fair amount. One thing that's really interesting is you see all that pseudox debris on the ciliary body, and it doesn't absorb as well. What I'm interested to know is if an externally applied cyclophotocoagulation isn't affected by that debris that's over the top and is more effective in those situations. And by the way, you don't have to be mucking around underneath the iris close to the lens. We're going to move on to post-operative care. And